Yes, that was beautiful. Thank you so much. Thank you. My name is Charlotte Little. I am the Tribal ALTCS Specialist. I'd like to thank everyone for joining our, again, first quarterly Tribal ALTCS meeting for this year of 2023. Before we begin, I'd like you all to take a look at the agenda with me, or if you've already viewed it, we have some pretty good, important topics to discuss today. Again, if you have any questions, please raise your hand and it'll be at the bottom of the bar here or on the chat, or you can ask your questions in the chat box. Okay, let us begin. So here is the agenda. As you saw, we already have done the morning prayer and now we're doing the welcome. I'd also like to share with you the meeting reminders. Please mute your computer's microphone. Use the chat feature with comments or questions. Ask questions once the speaker has finished. Or sit back, listen, and enjoy the meeting. This meeting will be recorded. Here, we'd like to share with you a motivational quote. When people feel safe enough to raise their hands and say, I made a mistake or I need some help, the leader has created an environment where people feel safe to be themselves. That's a beautiful quote. And we will start off and I will turn it over to our tribal coordinator, Bandana Chetty.
Good morning, everyone. Today's icebreaker is to getting to know you. Next slide, please.
So
We'll be
go ahead. Sorry.
We'll be asking some. Okay. We'll be asking some questions. As we post the question, we ask that you type your name and your response in the in-call message of this meeting. We'll be keeping track of who responds first, and we'll have 2 winners from the icebreaker today. Are you ready? Okay, here we go. Next slide. Have you traveled outside of the United States, and what country or countries did you travel to?
Type your response in the comments, call messages. Okay, Annie and Ernestine has gone to Spain and France, and Annie has gone to Hong Kong.
Wow.
Okay.
Okay, let's go to the next slide. Do you play sports, and what is your favorite sport?
Christina. Oh, she does not play sports. Okay.
Okay.
Medina. Okay. White Mountain, basketball and volleyball. Who is this? Rydell? Oh, baseball and volleyball. Okay. And Casey, mud wrestling. Okay. Oh, hi, Eileen and Rydell. Thank you both for responding.
Okay, let's go to the next question. Do you love to bake cookies, and what are your favorite cookies?
Annie, chocolate. Christina, sugar cookies. Let's see. B, M&M cookies. Yvonne, oatmeal. Medina, peanut butter. Chocolate and peanut butter. Oh, that sounds good. Sugar-free oatmeal, peanut butter. Chocolate chip, good. Yum.
Okay, let's go to the next slide. Do you love to sing? Are you or have been a member of a singing group?
Annie, is it yes or no? And it looks like we have, I like that, Diana, only in my car. Church choir, nice. Traditional. Yes, and just back up. High school, nice. Very nice. Well, that's a singing group in church. So,
Okay, let's go to the next slide. Do you have 3 or more pets? What kind of pets do you have?
no pets for Christina. White Mountain, you have dogs. Oh, Yvonne has 1 dog and 3 cats. Casey has dogs. How many dogs, Casey? Ernestine has 3 cats and 1 husky, 1 healer. Diana has 5 rabbits and 1 chicken. Casey, 3 dogs, 1 outdoor and 2 indoor. Joni has 8 cats. And I like that, Cheryl. So, Diana, we're going to ask you for eggs.
Okay. Next slide, please. Through email, we will let you know who is the winner. Thank you, everyone, for participating in our icebreaker.
Thank you.
Thank you so much, everyone, for participating. That was really nice. Okay, so next on our agenda, who will be presenting will be Rachel Connolly, who's our Tribal ALTCS administrator.
Good morning, everybody. I'm going to turn off my camera because it's really distracting. Even though I try to hide myself, I'm still right here on one of the screens. So I'm going to go ahead and just turn it off. And everyone else who was presenting, you can do that too, just so that, you know, we're focusing on our presentation. So I like the quote that, that the team has agreed to put on our presentation. You know, when people feel safe enough to raise their hands and say, I made a mistake or need some help, you know, as a leader, you all are leaders in this meeting. The majority, maybe you're the lead within your health plan. So it's really good to, you know, present this at the leadership level, because your team should feel safe enough to come to you and ask you for assistance or help, and even when there's a mistake made, they feel comfortable that they can come to you, because most things can be fixed, you know, especially with NPMMIS, most things can be fixed, and that's where we do a lot of our work from. So with that being said, you know, we really wanted to focus on, again, to reiterate EVV, you know, the requirements of EVV as a health plan. I know that we work very closely with the providers on the access side when we were implementing EVV. On the tribal long-term care side or the health plan side, it's different than what the managed care organization is. For tribal long-term care, really the responsibility was for the tribe was not to ensure all providers were in compliance. It was mainly our responsibility at the access level to work very closely with the health plans. with the providers to ensure that they were in compliance with EVV. That was one part of the implementation. The other part of the implementation was the tribal side. And we've been educating on this. We've been bringing this issue up within the past couple of years about EVV, letting you know what needed to be done, what your case managers needed to do to ensure the updates were happening. But as we hit the last 2 weeks prior to hard code edit implementation, it was during the holidays. It was a lot of work that Sonny, myself, and other team members, I even had to include other units to come and assist us to do the outreach to the providers because they were not in compliance yet. The majority of them were not in compliance. These are most of the providers that were that service our tribal community, tribal population. So we did a lot of leg work on our end to work directly with the providers to ensure that they were in compliance according to the rules and regulations of what was required for implementation. So next slide. So as we all know, the reason why we wanted to bring this up was when there was outreach made to the program, to the providers during those last 2 weeks, they needed the assistance of the case manager to update PMMIS. But we found out through some of these providers that some case managers were telling the providers, we don't know anything about EVV, we don't know what's going on. We were not told, we were not informed. That was pretty much some of the comments that were coming from the providers. So it was really challenging to get them on board to ensure that they were in compliance to, this federal mandate. They really needed to ensure, we needed to work with them to ensure that they were providing services. And of course, in our tribal community, there was challenges of internet, the bandwidth, the cell phone, the phones disconnecting, no reception, elderlies not understanding, our physically disabled members not even, able to, understand what the process was, what the reason and rationale was behind EVV. And for the past over a year and a half now, we have been bringing this to the quarterly meetings. We have really been trying to encourage you all as supervisors to educate the member at that level. Educate the member what it was, the reason for it, the purpose of it, and what it was for, to ensure that, to ensure that they were receiving the services, and to ensure that, someone was there to provide that service to them to avoid any quality of care concerns on your part, and also as a monitoring purpose at the state level. So, because we do monitor the clock in and clock outs at our level at the state level. So that was some questions and concerns and feedback that we received from providers. Providers were working directly with the members that you also case manage, and they informed us that some members don't even want to switch over. Some members are resistant. This is the first time they've heard about it. This is the first time that, the communication was provided to them, and they don't want to change their agency. So at the end, it was successful. We were able to implement EVV, but those were some of the things that we heard back from providers, and even received some responses from members. So just to reiterate that this is an ongoing process. And when I say ongoing, I'm basically talking about some of the things that we've already covered, which I'm going to present again today. Next slide. So as we mentioned in the previous presentations, so the next couple of presentations are going to be kind of a repeat. And just if you could, as leaders at your level, share this information with your case managers. Let them know that these are the services that are subject to EVV. And so they are aware when they are authorizing these services, it really does impact on the SANDATA side, because we're able to see the SANDATA system at the state level, because we have access at the administrator level to see what the provider is doing, to see what the provider is the authorizations that they are receiving from PMMIS. So the end of the day, when your case manager updates the prior authorization in the PMMIS, that night, that information will be rolled over to the Sendata system. So on the Sendata system, the provider will be able to see, what has been authorized. They can also see it on the portal. So there's a lag. So you may update it. Your case manager may update one of these services in PMMIS. They'll simultaneously see it on the Access Online portal. They're able to see their PA, but they won't be able to see it in the Sendata system till the next day. So they do have that reassurance. And we all know that any services that Medicaid or any health plan, it doesn't matter if it's Medicaid or other insurance, unless it's urgent or emergent, you will need a prior authorization. So they will need to do prior authorization. We're really reiterating that with all providers now. You should not be rendering services unless it's emergency. You should not be rendering services unless you see the prior authorization. Prior authorization does not guarantee payment, but it gives them that security that, okay, this payer is going to pay me if I start rendering services. So for that reason, we want to reiterate again with EVV, it's really going to have to be a partnership relationship with the case managers working with your providers that you actually provide to the members to choose from. So with that being said, please remind your case managers that these services, when you're authorizing these services, you really have to be mindful in the time frame, how long it takes for you to authorize them and to continue authorization. You can come up with a plan on your side to ensure that they're getting it prior to services being rendered. Next slide. So again, this is one of the ones that we've brought up before. Some case managers were still seeing that the modified date, they're using the 1/1/80. That was a default date. That was a default date that Access came up with and said, we'll start it from here. It really is the responsibility of the case manager to ensure that they are authorizing according to the dates of services. So for instance, you have the first one there, 1/1/2021 to 1/31/2021. Case managers should not be putting the MNDD date. There should be an edit error that comes up if they put the MNDD date as maybe 1/15/2021. It's after. It's going to give an edit error. So for that reason, they really need to make it either the day that they assessed, or in this case here, we see the review was after the dates of service were set up. So they would need to set this one up as 1/1/2021. So whichever one comes first before the dates of service start, that is the date that they should be using. So otherwise, it's going to come up with an error, but they should not be using the default date at all. Next slide. So I just went over this on the MNDD. It should not allow invalid dates. I'm pretty sure many of them, I think if they've been using it pretty well, there hasn't been any issues or concern related to that. The effective dates cannot be greater than the effective date of service. We just kind of went over all of this. So please revisit this with your case managers and let them know that this is another area that was covered by Access. They are still hearing concerns related to the EVV, ensuring that prior authorizations are updated in PMMIS accordingly. Next slide. And as I mentioned, the effective date, this is basically what I was talking about. Make sure that case managers do not use that 1/1/80 as the MNDD. It has to align with the last review date or on or before the service line effective date. Please make sure that they are doing that. I can't stress out like too much, but it's really has been an issue on the SunData system. Next slide. So in cases like this, I know you see that with this case here for 8/1/22 to 8/31/22, the units authorized were 0. But when the provider was going to bill, they're not able to bill because on the SunData site, they're going to see 0. The zeros cannot be put in there. They need to make, if they selected a provider, they need to ensure that they are putting the units in there. And this is really a snapshot of a live service plan. So please make sure that case managers are setting up services per their assessment to ensure, because like I said, this information is communicated to the SunData system. Next slide. So this is where we are now. As of January 1st, 2023, my team has worked really hard, and I know all of you have providers within the tribal community that you utilize, and I'm pretty sure that you provide a list of providers to the to your members that you service within the tribal community. So it is really the health plan's responsibility to find these providers, have a, establish a list of providers within the community and give the member a choice to decide which agency they want to go with. Please really be mindful of that, because during this transition of moving from soft edits to hard code edits on the SunData site for the providers, we were also informed that some members were not given a choice. Some members were told to go with a specific provider. So if there is a quality of care concern, or if there are any concerns related to why your case manager is recommending an agency, there should be a report that is sent over to Access in the quality of care system, and to ensure, hey, is this something that Access needs to look at? Is there a provider issue that we need to look at? But at the end of the day, the case manager should have, or you as a program should have established a list of providers within your community. Are there any new providers? Are there any providers out there? Add them to your list within the GSA that you guys service, and provide it to the member and allow the member to have a choice. That's more and more spoken about now. So there was a lot of things that were uncovered during this EVV project of members' concerns and also provider concerns, and then looking at our system and how even we heard on the health plan side, how do we know that case managers are doing what they're supposed to be doing when these updates need to be happening? So with that being said, during the last 2 weeks of December, again, I said my team and I completed an outreach to approximately 45 healthcare home health agencies. And by the end of the month, we only had 3 members with 3 agencies that were refusing to move. And this was due to, as I mentioned before, there was not any communication that was provided to the member. The providers were resistant. They did not want to comply with the requirements. So we really had to push and say, look, you really do need to move. I know we had a lot of feedback, and in partnership with the one health plan or the health program on the Tribal ALTCS side, they did an awesome job to do the outreach, to do the education, to move those members successfully. So that took a lot of work, and it wasn't just at the Access level. Even though the last 2 weeks, it was really a lot of work, we continued to ensure and make sure that education was being provided to you all to continue and communicate to your case managers to let them know how important it is that they really need to keep up on their authorization, because it does impact on the SunData system. So it was great work. There was over 1,300 members, and it was a lot of work. Again, we do appreciate everyone that was all part of this. to make it work. We are now on the Sendata side. So on the Sendata side, we are now seeing, we are in the future, we will be looking at, people who are clocking in late, people who are having challenges with the device that are given to them. But on the case manager side, please reiterate, ask questions about the device. How is it working for you? Are you getting connection? Does it work good for you? Because this is part of their daily life now. So please get some feedback. If there's any questions, concern related to EVV, please don't hesitate to send it over to me. What have you heard from the members? Are the members comfortable with it now? And so please continue to do that on your end and educate your case manager the importance of prior authorizing these services. Next slide. I believe my next slide is questions.
Rachel, there was a question. Diana was asking if any of her offices was and what office. I think we can tell you that the one office that the 3 members were out of was Tuba City. And they did an awesome job of getting those 3. So out of those 1,300 members, as Rachel said, only 3 of them had to be moved, and all 3 of them were out of the Tuba City office, but they did get them moved very quickly. It was very good. So did that answer your question, Diana?
It looks like it did.
Oh,
great. Yeah. So we got everybody to the agencies that are in compliance. So now what we're doing is we're rotating. Basically, Charlie's on this special mission. She's on a special project, or I should say Mission Impossible right now, or I should say Mission Possible, because she has been doing it. She will be monitoring it off and on until we come up with a plan of who's going to continue to update all of this EVV and working directly with the providers to ensure that they continue to be in compliance. Okay. So the next presentation for me is prior authorization. Again, I just spoke about part of prior authorization. Go ahead, Cheryl.
Yeah, I think, Christina raised her hand, I believe related to one of your previous slides. Can we have her ask her question?
Sure, go ahead.
Thank you. Go ahead, Christina.
Hi, this is Christina, Native Health. My question relates to your providers when you're stating that members have a choice in their providers. One of the things that we've been encountering is that we have an agency that's going to tribal council and proposing contracts with them, stating that they're the members' first choice for home care services. We've been trying to educate our members, saying that that's not accurate and that they do have a choice in which providers they use.
Mhm.
What would you suggest in that situation where we do have an agency trying to establish contracts with tribal nations, stating that they're the only providers that they can use when it comes to attendant care and home health services?
Well, with Native Health, they serve you all service multiple tribes, right? I will make White Mountain as an example, because each tribe is a sovereign nation. We at the state level have to be mindful and respectful of their sovereignty. So if a tribe decides, you know what, we only want these providers, and it's really whatever length of research investigation that they do on their end, and they decide, you know what, we're only going to have these providers providing services within our community. And also, I know Navajo Nation has went the route of establishing with certain providers, establishing a business license through the nation. So every tribe is different. It's really up to the tribe to decide which provider agencies they want to have within their community. But as we mentioned, and when we met with White Mountain, we did let them know, you do need to make sure that you give these members a choice. You can't just have one. So you need to have at least 2 that they can choose from, because members do have a choice, so that with that aspect, I think this provider agency was aware of that. And, even though it was taken to the council, then we then met with the tribal leadership within White Mountain, and we did let them know, yes, it's good that you're doing this, establishing a network of providers, but we really need you to understand that members do have a choice. We can't force them to be with one agency. So it's a tribe by tribe situation, but if we do hear that it is true, I mean, there can be those conversations, then the tribe will then, that provider will then, or other providers in the community will then reach out to us and say, hey, this is what's going on, and we'll do the outreach to that tribe and say, is this really what's going on, and provide that education. But because they are a sovereign nation, they can do that if they want. But we at the access level have to come in and say, you have to give the member a choice, at least look for another provider within your community that's able to provide that service. Did that answer your question?
Yes, that was very helpful. Thank you.
Okay.
And Yvonne raised her hand as well. Go ahead, Yvonne.
Yes, thank you. I'm encountering the same situation as Christina here with the hospital here. I found out I don't, let's Ernestine know, I don't has not been affected to ALTCS member, but I know other elders and some relatives that when they come to this hospital and they had asked that they want, there's an order for a procedure, but the tribal member says, well, I want to go to another hospital because I had it done before there and etc. Well, the hospital refused. They said if you go to another provider that they did not choose, or they said they can do the procedure here at the hospital, that they will not pay for it. And I question that, but I wonder if that was true. Apparently it is true because I had talked to several people. And the other thing is that when a tribal member comes in and they ask for some treatment, they are go to where they do a referral. If they go to a different referral, a different provider, they will not pay for it. So that's the question of the member's right. But I have not come across that an ALTCS member, unless they have, but they don't say anything. They just follow whatever the hospital says. So that's my encounter in that.
Thank you for that comment, Yvonne. I know you do a lot of advocacy at the member level. We always have to remember, and this is one thing that I continue to try to reiterate across the board. You know, we are dealing with members within our own tribal communities. And we know that the case manager has really established a relationship with some of these members. And to continue to ensure that these members are given those choice and have access to those services, it's really important for them to continue to have that communication with the member and stay on top of things, what is going on in that community. And also when it comes to like Christina's question, always feel free, you know, like we said at the beginning, you know, we have an open door policy to all our plans that we are responsible for working with as a partner, that if you have any questions or concerns, please get it over to us. Don't just sit on it and, you know, maybe that's what it is, maybe that's not what it is. If you have contact information of who we can reach out to at the tribal level, we will do that. You know, we'll ask these questions because members' choice is a really big thing. It is a part of their life for years and years and years. Someone always spoke for the member, and we know our elders. My elders, I knew my dad, you know, he was very stubborn. He wanted things his way. And then also traditionally, I knew where to be careful at and why to say or not do certain things. I understood that. And for that reason, I've advocated for my elder in that way of knowing the tradition and the culture. So you all are responsible in your community. When it comes to the sovereignty, we really have to be very careful. You not only report to and to stay in the guidelines of the the state policy or the federal requirements, but also you do have your own leadership internally. And because your leadership is sovereign, whatever they decide, you really need to speak to them about in their leadership, their how they can help you resolve some of these issues. Like we have other issues like DME, you know, we have issues with those services in the community. Who can provide it? Who can't provide it? You know, you're aware of those things. Those things need to be taken to the tribal leadership level, because some of these providers don't want to go onto tribal land and to do services. So, and they need to, the nation to reach out and say, hey, we can do this or we can do that. This is how you do it. This is how you get it done. So it really has to be balanced, but giving the member an option. I mean, Medicaid will pay for the services that are covered for these members. Having, you know, at the tribal level, those are more discussion, like Yvonne said. She's advocating, she's, you know, saying, hey, at the state level, this is appropriate. I've heard and I've seen her do that work before. It's really has to be done at that tribal level to really let your leadership know, you know, this is a need, this is what's going on, and being that advocate. I know Joni does that quite a bit too at her tribal level. So really that's, you know, that's where it's out. So we do provide the services, you know, we will pay for those services that are covered, but at the tribal level on tribal land, who conducts business there, how it's done, how they have to be in compliance at the tribal level, that's really up to the tribe to decide that. So we can't come in the state and say, you do this, because then we won't be honoring our IGA. So it depends on the service, but when there is a concern, when members are not given a choice, that's when we can say, hey, you know, we'll have questions to the tribes, and pretty much most of the tribes do understand, you know. So continue to report that to us. Don't wait till it's an urgent need. I always say be proactive. If you've been hearing this, you know, get us in the loop of it and let us see what we can do to support.
So Rachel, Casey also put out that there was a similar issue. One home care agency also takes a position that they already have, that the member has already chose them, and they're asking the case managers, why are you giving them, the member, another choice after services are ongoing? I think you already answered that, is that it is that it is member's choice, and but I'll let you go ahead and reply to him.
Okay. We do hear quite a bit of those during the EBV, you know, the last phase of it, of the hard code edit implementation. We heard that, and we also reiterated to them that it was their choice, you know. So if a case manager has assigned a specific provider to provide services, we are assuring that, you know, under your leadership as supervisors, you have educated your case managers, and that you have established a list, and that you are fairly giving this list to the member and say, you have a choice between these providers. You know, it's really up to them. They can switch over in the middle of the month. They can try one provider and that might not work out for them. You know, it's really their choice, you know, to decide who they want to go with. It's just like you and I, you know, we drive into the drive-through, you know, we have a choice of what we want to eat. Nobody's going to force us to eat, you know, a double cheeseburger when we only want a small burger, you know. It is their choice. It is a benefit that Medicaid does pay for these services, to give that choice to members and to be fair, because, you know, we've heard, well, case managers are, you know, directing all their members to this agency, you know. That's not necessarily, that wouldn't necessarily be true if you all had a list of providers that you share with your members, and give them that option and say, every member we meet with, we give them a list of providers, and it's really, we leave it up to them to make that decision, you know, to go with an agency, and hear your members out too. You know, if they don't like a certain provider, listen to them, you know, and because sometimes we hear it at the state level. This provider was chosen for me. You know, who chose it for you? My case manager. It's like, no, that's not the way it's supposed to be. As Cheryl mentioned here, it's all part of person-centered planning, giving that member a choice. So I hope that answers your question. Who was it that answered? Oh, Casey, But if you feel that there is a provider that is doing this, or where they're bribing the members, or where they're going to the members' house consistently, please report that to us too. Those are some things that we have done also in the past, where we outreach to the provider and say, why are you doing this? We don't only say it's coming from the case manager, but more than likely we will make contact with the member and say, is this really happening? If it is really happening, we will then follow up to ensure with the provider and let them know you cannot do this with the member, because they have a choice at the end of the day who they want to go with. They can be with your agency one day and they can go to another agency another day. That's really up to them. It's where the coordination of care happens with the case manager.
Okay, and it looks like Rydell or Eileen has raised a hand. Go ahead.
Can you hear me?
Yes.
Yes, we can hear you.
Okay, good morning. Talking about providers, when it comes to bribery and gifts, would it be the responsibility of the member to report or the case manager?
Can come from either or. It doesn't matter who it comes from.
Because I know a lot of that goes on, not just with the white bound, but across the country. And I know a lot of the members won't report it, document it. And that's the process that we try to enforce the documentation. But I just want to have understanding where it's supposed to come from, member or case managers. So thank you for that.
Yes, it can come from anyone. Complaints, concerns, it can come from anyone. We shouldn't restrict the member to be heard. If it's reported to the case manager, let us know. I mean, we have to have some sort of tracking mechanism on who is saying this, because it could be, we could do an outreach to provider and educate them, right? And they say, no, it's never happened before. But then now it's been reported by a certain program that 10 members reported the same thing. So then we need to say, we're getting this report. It's not just one report. We have documentation and proof that this is consistently happening. And, we can escalate it even higher than within our program level here within Access, so they can be, reached out to, and, provider registration will be made aware of.
Thank you. Oh, another Rydell, go ahead.
Let's add what I was talking about, because throughout the winter, providers, especially I know I hear from up in that whole nation, providers buy a load of wood, and to me it's like that's a gift. That's even the members will bring that up. They bought me a load of wood, but that's like the source of an access that's a violation. I mean, is that considered a violation of access?
Well, I believe there has been some, with ARPA, right? It might have happened quite a bit this past couple of years. Providers were given certain amount of money for within the ARPA funding, right? And they chose to use it however they wanted to use it. Some of these providers were utilizing it for mask, wipes, Clorox wipes and other things to ensure the safety of their workers. And also some of the members were fearful of COVID or contracting any type of virus. They weren't able to go out, so they couldn't get woods, or they were just scared to even talk to anyone. So they utilize that money to use it for the member to continue to be safe in the home. And that could have been the reason why, but we will not know if it's consistently happening. And the members reporting to you, they told me that they wanted to stay with me and stay with them, and they'll continue to provide woods for me. If you heard that, those are some concerns that we would then need to follow up on.
Yes, that's what we hear. So that's why I wanted to share that for everybody across the board. So thank you.
Thank you. Cheryl raised her hand.
Thank you. Yes, that does relate to what is going on right now. Navajo Nation has declared an emergency due to the storms that have passed through, and now that the roads are getting muddy, there are a lot of very rural elders out there, and people just from the community are going out and either taking their old tractors and grading the road for them, bringing them loads of wood. I think those are in-kind services that the communities are trying to help with. So just being aware of your tribal executive orders is really helpful. Thank you.
I would also say document it in your person-centered planning. Document those things that are happening, because it really does also highlight, you know, what the tribe itself is doing. You know, we did have, I mean, across the board, there's always these types of highlights. I always bring it back to our internal executive meetings, and they are very impressed on the work that you all do. So highlighting that really does help out too. But as far as a provider saying, you know, we're not going to continue services for you, or we'll continue services with you, and part of that is we'll give you woods, we'll give you groceries, we'll give you gift cards. You know, that's different, you know, because member can say, well, I want to stay with this because they do this for me, but I don't want to go with this because they're doing this for me. They're not doing the same thing. Their service is providing attendant care services. That's what they ask for reimbursement for. So that being said, I hope that answered your question. And if you are concerned and it's multiple members complaining, bringing it to your attention, always let us know, and we can kind of assist to help you with that, of reaching out to the providers, because these are access registered provider at the end of the day.
Thank you, everyone.
Okay, so the next presentation I have is prior authorization. I know we already kind of touched it a little bit, but I will go ahead and kind of reiterate of what has transpired within the past year. So our new reporting internally within Access is very detailed. It does really cover, you know, how much we're getting from each of the tribe, how many PA requests that we're getting. We rolled out this new report as of January 2021. And we started working on it, and we have internal data. It wasn't really a reporting that was captured as what we're reporting now. My team gets this report every week. They see what not only our performance of our turnaround time, but also how many requests are we receiving? What does it fall into? What category of service does it fall into? And how do we monitor this at our level? And this slide is actually shared at the executive management level, because they really want to know what's going on with our long-term care plan. So this report was created, or we started working on it in 2021. In 2022, the new report was developed to count the numbers of PAs requests received daily. So we have a report that we can track this, how many was received every day. You know, it even goes down to who worked this PA, how long did it take each person to turn these PA requests around. And as a whole, it does show the demonstration of the performance of each of the employees here that work for the long-term care program. So we did see an increase in volume of PA requests that were submitted. And we see that if you look at the 6-month time frame between January 2021 and June 2021, that's 6 months compared to July 2022 to December 2022. And most of the biggest population that we have is always Navajo Nation. We get a lot of PA requests from there. So we can see that we can actually say that in January, there is an increase in the number of requests that we get, because those are the winter seasons. We can actually say winter season. In the summertime, there could be floods in the south area, rain. There could be other reasons why, but this data is now allows us to track and see where is the service need more high, what area of service is more high, what can we do, what can we show you so that you're aware of what's going on in your community. So this is what we came up with for state fiscal year 2023. So far, we received 2,228 PA requests in total, and that's both to the nurses for specialty rates and also special services and the tribal ALTCS coordinators, what they authorize at their level. Next slide. Okay. So this is another report that is part of that same report. There's 3 different purposes of just one report. We are now tracking, and I think I've mentioned this before, whatever your case managers submit, we are tracking it based, we call it the PA status. What do we, at the end, once the team members get the PA request, they reviewed it, they see, is everything included? What's happening with this? How is this working? Do they understand? So I really want to focus on the 4 bolded ones, especially the one in red. But we'll kind of go down the list here. Duplicate, we did determine duplicate and missing information or multiple members. All 3 of those we determined, and we reported to the leadership level that this, of course, Navajo Nation is always the one that submits a lot of PA requests. So out of that 2,228 PAs that we received, 412 of those were duplicate. That basically means you've already submitted a request for this PA or for this service, and then maybe for whatever reason you're submitting another one again for the same thing. So we're getting that, we've received that many duplicates for the PAs, and which kind of, if my team is already looking at it, or if they've already looked at it, they're getting another PA request and they'll be like, did I just look at this? I thought I just reviewed this. And it becomes that work where they really don't need to look at it, but they already have it in our system. So please make sure that you inform your case managers that they need to be mindful when they're submitting the requests, and they will get a response on that one request. Missing information and multiple members also hadn't, that we know is really the fax. Fax, maybe their prior authorization got cut off. You know, the PA didn't come through completely. They think maybe they got an error message on your end when you were faxing in your documents. And some of the pages were missing. We didn't get the whole packet. And then we're seeing, as the nurses are looking at it, the coordinators are looking at it, and they don't see all the information, but you're like, oh, we did submit everything. What are they talking about? So those were some that we received that we would need to ask for more additional information from you. And most of those information, they will be communicated on the CA 165. And that's what we have been doing, is I've instructed the coordinators and the nurses, when we receive a PA request, please document it. Please let the case managers know so they can go to their CA 165 screen and know that Access received it. So they don't have to send it back in again. Or if there's any information missing, you'll get a response on that. Make sure that they're monitoring their CA 165. So that really reduces phone calls or emails. Go to the CA 165. Did they receive it yet? If there's any follow-up, it'll be on that comment screen to ensure that, yes, they did receive it. I feel okay. If there's any questions or concerns, the outreach will be made to you. And then we also, even though it's not a high number, no PA required. Those, as we all know, we ask for PA when a member needs services. So if we're receiving PA requests that doesn't require the state to approve it, that kind of slows down the process of the member receiving the services. Remember, all of this impacts the member receiving the services. So if you're waiting for an approval from Access, when the case managers could have approved it at their level, and they would have received services maybe the next day, the referral was sent the next day or the same day, and services would start sooner. And you're sitting and waiting for Access to respond on these PAs that don't require PA. It really does slow down that process for the members to get the services that they need. So please let your case managers know to use PMMIS to check the status of a PA that they submitted. If you're not hearing anything, I think we've reiterated this over and over again, something should be documented in PMMIS at least by the 72 hours that we received it and that we're looking at it. If it's something that is emergent or urgent, after the submission of the PA request, you can follow it up with an email or a phone call and say, hey, I just submitted this, it's urgent. Whatever the case or scenario may be, they'll look for that PA. Or if it's really urgent, they can go into, any services if it's needed, get the member to get the services that they need. But if it is something that you need follow up on right away, let us know. And there has been cases where my team has actually reached out to the team, the imaging team, and said, can you pull that in? We really need to get this and review it right away. So please make sure that they're using their PMIS system to check updates if they have any questions, so they don't continue to send in duplicates. If there's missing information, please make sure that you let them know that check your emails, check your notification from Access. If something was failing, please work with the coordinators. As for issues with fax machines, old fax machines, we don't have the right equipment, all of those are something you really need to address with your tribal leadership, whoever your leadership is. If your case managers are reporting this to you, that they're having issues with technology issues, those are something you really need to communicate with your leadership if your case managers are reporting it to you, because we really don't have a way to, say, here you go, here's a new fax machine. We don't have that capability. We provide the funding to ensure that you all run the program on your end. But if it's a technical issue that we can work through it, Sonny does a great job in working with the programs and the tech people to ensure, is it something on our end that we need to fix? So please keep that in mind. So that's what we're tracking now. And my team will continue to provide training on any of these areas for duplicates, missing information, and no PA required, or multiple members on one fax. Those will be the ones my team is really focusing on, because we really want to get services to these members as quick as we can. And PA is part of that, because most providers do not want to render services unless they have a PA. Next slide. Oh, that was my last slide. Thank you.
Okay. We're about 15 minutes behind, but we can make it up along the way, I think.
Here's my hand.
Okay.
Departments.
I'm sorry?
Your fax still doesn't get through. Question.
Okay.
Is it read out? White Mountain. Sorry. And like I shared, you talked about the fax line issues. We checked we checked with our IT department with White Mountain, and we even made attempts with other departments, other programs across the reservation to fax to Access, but it's just still the same issue with the fax numbers that were given to us. So our lines are good here. We're able still to fax to other facilities, but for some reason, directly to Access is still an issue. Not just our building, but we tried other programs, like I said, other department facilities, like we said, but still nothing to Access. So, like you said, it's your end. This is ongoing, so we just want to try to figure out a way to fix this issue.
Okay.
Well,
Yeah, with those cases, right now, just send it over to Sonny, because I know that our ISD team does testing between both sides. Once we report it to them where the issue is, they'll look at it on their end, and I believe she's even gone to the extent of having one of our IT, the technician, work directly with the program's IT and kind of drill down to where the issue was. And I know that has happened with some other tribes before.
Mm-hmm. Yeah. Okay. Thank you, Rydell. I'll get with you on that later. Okay. And if anybody else has any issues, so, certainly email me. We'll continue to work on it and see if it is on our side or where the issue is. Okay. So I'm going to cover several topics here about the weekly reports, our daily roster issues that we recently had, NEMT escalation, and the open line request form has been updated. So go ahead and next slide. Okay, so we have been hearing, my coordinators have informed me that they are not regularly receiving the weekly no service line reports, the projected overdue reports, or the 029-108 reports back by the close of business on Wednesdays with those comments on them. there are some of you who are really good about it and are very prompt, and we do want to acknowledge those of you who have been very prompt at it. But it is really important that we receive those back by that deadline, and if you can work very hard to get that back to us. If you have a delay or something, I really need you to speak up to the coordinator to explain why it is, can cause a bit of a problem. So, but we are repeating, as Rachel had indicated before, is our upper management does look at some of the stuff. We report things to them. They know what is going on, and it is really important. We keep track of things on our end to see where we are with reports, where we are with overdues, because it's really important to access that our members are receiving the services that the case manager has gone out and reviewed with the member, with the authorized rep, to determine that those services are provided and that the reviews are conducted on time. We do understand that there are issues, and some of you are really good. Some of you are very good at documenting on the CA 165 screen any issues, and that's where you should be communicating, because that is a communication with us. That's how we can see it without having to contact you, is you are telling us you've made repeated attempts or whatever the case may be. If it comes down to, something where you're unable to contact that member, that's when you need to reach out to your coordinator and see what we can do on our side. Although there's, since the PHE, as you know, we have eligibility has not been disenrolling members, but we are starting to roll back a lot of those restrictions and different things, because the public health emergency is winding down and will be coming to an end. The last we heard was April 1st. So those things, some of those restrictions that were in place during the public health emergency, some of those will be lifted. But we do appreciate all of you who really work very hard to try to make sure that you get those services out to the provider, or for the member, get the reviews completed. So we do want to acknowledge those of you who are really good about it. And yes, I believe the emails do say Wednesday, so we try to get it out to you on Monday, unless there's a holiday in there. But otherwise, we get it out to you as soon as possible on Monday. We do need those back by Wednesday, and I think it does say that in the letter. Is that correct, Bandana? In the email, Bandana and Cheryl, I think it does say that in the email, correct?
Yes, that's correct.
Okay, thank you. Okay, next slide. Okay, so we do know the week of January 17th, there was a large number of admin out errors on the daily rosters, and it affected Native Health, White Mountain, Gila River, Tohono O'odham, which the majority of them, unfortunately, did hit Tohono O'odham and Pasquayaki. There was a couple with Navajo, but fortunately not too many, and there was a couple with San Carlos. Fortunately, Hopi did not affect any of the Hopi members, but it was really bad. There was an update that occurred in it. Obviously, something happened, and there was it just massively went through and did some admin outs. But my coordinators did exactly what they're supposed to do, is they went in and they caught those enrollment errors, and we submitted it. We got them corrected. And those were, it was a lot of work. I can tell you that they worked very hard to make sure that those members got corrected back to the correct tribal program. And those errors, the corrections were made on January 18th and 19th daily rosters. So we do our best to catch all the errors, but it's really important that we need you to be another set of eyes to look over those rosters and just make sure to see if we've missed something. If you have a question, please make sure you let your coordinator know or let me know. But for your first stop should be with your coordinator to say, hey, I see an error on the roster. So if you could be looking at those, just make sure we didn't miss something. But we're doing it was a lot of work, like I said, but we got it done. So next slide. Okay, so what we did find out is that with the recent enrollment errors, that some of the members were reporting that they got a new access ID card with a different health plan. We would like to have you just instruct your case managers to review the CA 165 screen. And I provided a snapshot here. This is one, happens to be Pasquayaki, but if you look at CA 165, it shows the last PC right there, and it shows 190075. Whatever tribal program, that will show right there. So so if it's incorrect, please notify your coordinator as soon as possible. But if it is correct and they have been corrected back and they got a new one that says say Tohono O'odham, and they actually should be with Pasquayaki, you can inform the your case manager can inform the member to go ahead and shred that new one and use the one that has the correct health plan on it. So that should be their previous one. So, but again, just notify your coordinator if you see any errors, okay? Next slide.
Excuse me. Good morning.
Yes.
This is B. We're running into that problem. One of the nursing homes around Cottonwood or Sedona has been calling us on this one, and I did send that to Cheryl yesterday, but
Okay.
it lists us, but there was a correction made by Cheryl, but somehow it's still showing up having our number in her file. So
Okay.
I sent it to Cheryl yesterday.
Okay. I'll work with Cheryl on that and see if there's anything that we need to do. Okay. Thank you, B. I appreciate it.
Bye.
Okay. So the next thing we want to go over is the NAMT escalation. And we ran into an issue recently where a member ended up in out-of-state placement in an acute care setting. If you happen to have that happen, first off, we really hope that the say if it's a nursing home or whatever the case may be, that they are notifying the case manager that the member's being moved to an acute care facility. If so, the case manager should be following up with acute care to find out when the member is going to be discharged. Hopefully, the acute care is notifying you if they need to be moved to another place. Unfortunately, there are situations where case managers are only made aware that the member is moved to an out-of-state acute care facility after the member has been transported out. So, if you find yourself in such a situation where a member is out of state and in an acute care setting and you need to get the member back, you first of all, the first step would be for the case manager or supervisor to make every attempt to make all efforts to find an NEMT provider that would be willing to transfer the member. Unfortunately, with one-way reimbursement, that would be the first step, obviously. Next slide. And if the case manager is unable to arrange transport, and the case manager and supervisor, then they would be to contact your assigned coordinator, provide an email to your coordinator with written explanation of all attempts that have been made, as well as a list of the NEMT providers that have been contacted and refused. And at that point, the coordinator will escalate to the DFSM transportation team and CC myself to see if they can find an NEMT provider that will agree to transport the member. Next slide. If the DFSM transportation team is also unable to locate an NEMT provider that would be willing to transport the member, then they may, what we found out with this last time was that they recommended the case manager contact an ambulance provider to complete the transport, which would be appropriate in some cases. But what we did discover in this last one is that the ambulance provider said they could only transport from acute care facility to another acute care facility unless a member had specific acute medical conditions that required medical personnel to accompany the member during transport. So because this member was going from acute care back to a SNF, that was not possible. So once the coordinator has exhausted all efforts, then they will escalate that to myself or Rachel if I'm not here, a list of all the attempts that they have made, as well as all the attempts that the case manager or supervisor have made, including all the details. Next slide. Then the next step would be to see if we can get an approval for round trip transport. In this case, that's what we had to do. We had to escalate this up to the DFSM assistant director because that's who has to approve it. It can't be just approved at the tribe level, and it can't be approved at our level. This has to go to the assistant director, which is Marquet, and we would have to provide all of that backup as to what all has been done so that they can say, yes, okay, they can see the diagnosis of the member, what's going on with the member, what happened, that every effort was made. And at that point, the assistant director can approve it, because if an NEMT provider does submit a PA to the DFSM main fax number, it could result in a non-payment of the claim if it's not approved by the assistant director. So that is really important. In this case that we encountered, everything was done according to everybody made every effort, and we have to give kudos to the case manager and the supervisors. They made every effort that they could on their side to procure an NEMT provider, and the acute care facility in out of state was just hounding them, get this member out, get this member out. And so we were successful in getting the member out. So, but if you have that kind of a situation, just make sure you follow these steps, do everything on your side first, elevate it to your coordinator. If they run into where they've exhausted everything they can do on their end, then they will escalate it to me. I will escalate it up, and whatever the case may be. Next slide. Okay, and I think this is the last thing, is we have updated the open line request form. It is out on the digital toolbox on the Access website. And I know many of you have talked about is that the explanation section was not allowing you to put more than one line on there. Is that so it will now wrap and allow you to put more information. And there's an example, post a snapshot here, And I just put some information in there so you could see that it is allowing you to wrap and add additional information, so that, because sometimes there's a longer explanation than just one sentence. So thank you for those who notified us of that issue, and we did resolve that. And the link to the digital toolbox is right there in the form, is under that all about forms. And Rydell, you had a question. Any EMD providers need to be approved by the tribe with approved business license. Yes, that's correct. So you guys have since you're a sovereign nation, you do have the ability to approve or disapprove providers who can come onto your tribal lands. So that is for you guys to decide on that. That's correct. Okay, next slide. Okay, are there any questions? Diana, go ahead.
Okay, I have a transport company that is saying that they can't transport even if they are off the reservation because of the business license with the Navajo Nation. And I told them, I said, that's only preventing you to come onto the reservation and transporting within the reservation. That doesn't mean it's outside. You know, you can't do it outside, because this member needed to go from Payson to Scottsdale.
If they are an access registered provider, Diana, I didn't mean to cut you off. I'm sorry. If they're an access registered provider, they agreed. They have the participating provider. They actually agreed. They attested to providing services to our members.
Yeah. So that's what I told them. I told them that they're still obligated as long as they're access registered. They are still obligated. Even though we don't use them on the reservation, we can use them off the reservation.
Yeah, they're really not, no providers obligated to provide services to anyone. They have a choice. They don't have to. It's really up to you all as a program to decide. We have, like, again, like with the DCW agency, you have a list of providers that you use. You build those relationships with those providers, those concerns and those questions at your level. You have spoken to these providers and say, hey, this is who we are. This, you know, this is the type of services you would be providing to our members, you know, and making sure they're in compliance with whatever the tribe is actually wanting them to do to be able to conduct business on tribal land. But as long as they're an access registered provider, if the tribe is okay to use that provider on tribal land, and they've gone through whatever hoops they need to go through with the tribe, they can provide services to whoever they need to, just letting them know that if there's concerns or questions and you need our assistance, you can always have one of the coordinators reach out to those providers and explain, you know, yes, they can work with our members off the reservation.
Yes, Byron, go ahead.
Okay, I got a couple of comments, I guess. Well, this one right here, that you guys are the transportation portion of it. You know, we talked about how Navajo Nation, or, you know, we can't use people that are not licensed here. But our problem here is that we have a couple of stretcher vehicles that are not licensed under Navajo, and Navajo NDOT, not NDOT, but the NDOH would not, previous administrator would not approve those two those two companies, only because they figured, I don't know, maybe to me it was kind of, maybe, I don't know, their decision to me was kind of racist. But nonetheless, they weren't able to have those guys come on, even though we had none. I mean, we went to a point where we lost um, wheelchair vans, and then we lost stretchers. We only have one that is, I think they just have one vehicle, but we stretched that company out so far that we have a hard time trying to get a stretcher van. And when it comes to that, how, or the other way around, can access override Navajo to be able to get these two companies on? I mean, they've applied for Navajo, but they've been denied many times, and I think they're still not on the roster. And even to the point where NDOH has their own behavioral health appointments that they send people to. And I think the policy, it just goes to what they're responsible for, because it's only they mainly just approve those ones that have ambulatory, and we're not even considered. I don't think that I tried contacting them, but they wouldn't give me an answer back, why or what or how. I've even contacted them to try to get these other guys to get these stretcher vehicles on, but to no avail. Last administrator, I don't know if they have a current one or how that one's going to work, but nonetheless, how do we deal with something like that? Because we're stretcher vans is none out here. And then the other one is this pushing. I think it's pushing, but nonetheless, it's having to come on, ask us to do our weekly reports on Monday, and it'd be due by Wednesday. And with me, maybe it's just more or less, I don't know if it's an excuse or whatever it is that I have, but I don't think it's an excuse. Nonetheless, I've been out Monday, well, literally Tuesday, on this snow removal that's been going on, and trying to get these members to be, just to do a welfare check or something like that, that I've been doing, trying to contact people. And so Monday, I didn't, I wasn't able to get to any of these reviews or any of the stuff that report that could. And the same thing with yesterday. I had to go look for one that's buried in the snow, and she was okay. But nonetheless, I have another one that's coming up this afternoon that is way back in the woods somewhere. That they were able to rescue one from one, that's not our member, but it's one of the elderlies from the community that was had a camp way back up in the mountains, that had snowed, and they had to get a helicopter to go out there and pick him up. And so our supervision, gets delayed. A lot of the things that we do doesn't get done.
So
By report these things, and then we do the report. But then if you just do the report, yeah, it's doable to get it submitted on time and everything else. So anyways, that's just kind of more or less my comment on a couple of those things.
Okay. Well,
That's
Byron, the one thing I will say is that if you guys are utilizing that CA 165 and noting those issues, we do understand that is why there would be an overdue review, is due to weather. That's certainly an understandable thing of, you can't get through, you can't, but there's always a possibility of doing a call if that's available, doing a telephonic visit. But we do understand the weather issues. And of course, we do want people to, case managers to go out and see the member face to face, if at all possible. So those are things that, that we're seeing here. And Rachel would like to add more on to that. So I'm going to go ahead and turn it over to her.
Let me put my hand down here first. So there's a couple of things that you addressed, Byron, and that's the issue and concern that you have with NDOH, who is actually, it sounds like they're the ones who approve the transportation for the specialized type of transportation, I should say. So Navajo Nation does have new leadership. Okay, so these kind of things does cause barrier. If you as because you're the leader, right? You have people who report to you. If they're bringing barriers to you, you then should be reporting this to your internal leadership, because if we cannot come in and trump what your leadership decides to do, how they want to do their business. We cannot do that. We cannot come in and say, no, regardless of what you say, we want them to bypass their business license registration. We want them to provide this service. We can't do that because each tribe is a sovereign nation and we have to respect that. It's just like, you don't want anybody going into your house, without the invite. We have to be very respectful for that at the state level. So you spoke about there was previous administration. That was a decision that was made by them. You need to take it back to your internal leadership. Then it can be, presented to the new leadership the nation has. That's the proper way to do it. But the nation, that's when we will, if it becomes a bigger issue, we will then, we have tracking mechanism. You've reported it to Access. If it continues to be, there's no coordination happening for these members and this high need, then we can come in and you've proven enough. This is what I've done. This is where we've tried to speak to, that it typically would probably come from your leadership, and they will let us know, my team has tried this, my team has done this. We've talked to it internally. We've already talked to our leadership and nothing is being done. That's when we can then come in and speak to your leadership and let them know that there could be an access to care issue here. We really need to make sure that members have access to the community services or to the health services that we have, that they're allowed to within their benefit. So we can have that discussion at that point. So a lot of times, some providers don't make that effort. Some providers don't want to do what what's required of them, with the tribe requires of them to obtain the business license. It could be hearsay, it could be anything. We don't want to come in at the state level and assume and act on something that, we have little bits and pieces of information on, but it really needs to go through your leadership. You need to take these concerns to your leadership. They can then advocate for you to their executive leadership and let them know these are barriers, these are concerns that we have. And for whatever reason, if they were denied, that's really, really them. They then can let you all know, or they can come back and say, Access, this is the reason why we denied their license on tribal land. They might have justifiable reasons why. Leadership as a whole, and being mindful and respectful to each tribal leadership, for whatever reason, they made that decision. I'm not going to assume they made a decision based on whatever could not be correct. So for that reason, it needs to be escalated to your leadership. They need to escalate it even further if there's not a resolution found for it. And as for the pushing the reports on Wednesday, when there's already overdue, the reporting back to Access is not, you have to do this, you got to get it done, you have no choice, you're not in compliance. That's not the purpose of these reports. That is absolutely not the purpose of these reports. The reports is to help you as a leader. There will be times when, yes, you will have members that are overdue due to those barriers that you just explained, right? We do monitor it at our level. We have to monitor it at our level. Those reportings are shared with our executive management, but If we have no comments, if there is no response in CA 165 of what is going on with that member, we will never know who's visiting that member. I did do a presentation with one of the tribal leadership, and I said, sometimes, in very many cases, our case manager is the only point of contact, the only person who visits them every 90 days. That really happens. Some of our members live in such rural areas. They don't get visitors very often. So these visits are very, very important. So you cannot have a case manager have a very high caseload. You have to be mindful, what you're putting the work on your case manager, making sure that you're mindful of that. So, because these reviews have to happen at that time. If it's not going to happen according to what was documented in CA 165, case managers, when they're at their office, can say, I scheduled the review on this day. So we know that you're working on it. We know the barriers, or try to make contact. It was too snowy. We know what's going on, and we don't have to assume, or we're not saying you're not doing your job. We're not saying that. Each program does a very good job in making sure that they are actually trying to remain in compliance, but due to some internal tribal issues, yes, those barriers will be there. And yes, as Cheryl said, these are projected reports. These reports is letting you know what, as a leader, what's due this week, what's overdue. The main ones you focus on should be the overdue ones. The leadership should be focusing on the overdue. What's coming up, you're discussing, you're strategizing, you're planning with your case managers. I don't know if you have huddles. I don't know if you have team meetings. That's when you'll discuss, this is coming up. Do you think you can make it? How can we do this? How can we move things around? That's the purpose of that report, is for you to utilize it as a strategy tool to ensure that members are receiving services that they need to in a timely manner. That's what it's used for. It's not to push to say you're not in compliance. These barriers, these reports, when they go back up, I always say around the winter time, snow, weather has a lot to do with it, for one tribe, 2 tribes, 3 tribes, and then down south, this is the barrier. Around this time, monsoon season, they will be late. It's because of this reason why. So that's what this report is for, not to say that you guys are not doing what you're supposed to be doing. As long as you're communicating with us, we know what's going on, we're okay, and we can act on your behalf. That's what the purpose of this report is. But at the end of the day, we want to make sure that the members are receiving services, and case management is part of that service.
Okay, and Beatrice had a question, and Annie did. We answered Annie's, but go ahead, Beatrice.
Yes, I just wanted to comment on the inability for some of these transports, to come on reservation, especially when it comes to a stretcher van. And I recall some years back, we had a situation where we really needed a stretcher van. The transportation owner was very hesitant in coming out on the reservation. And so what we had to do was we contacted our chairman, and our chairman wrote out a letter authorizing them to come on for, this important service. So which he kept, with them when they made that transport out here, and just authorized him for that one day that they would be on reservation providing that transportation. So that's how we handled a situation regarding a stretcher van. So that's something that I think, is like Rachel said, it has to sometimes involve the leadership, to support your support you and in this way. So I just wanted to make that comment.
Thank you, B. And I know in White Mountain, it's the same way. It's a case by case situation. Since it sounds like Byron, This has been a barrier. It may not just be at your office. It could be other offices, or it could be other tribes that are experiencing this. So I would say really do get, because I know we had a transport, one of the members that Sonny had mentioned earlier, that member required a stretcher transport, you know? So it's something that if this is a need that there has been quite a bit of barriers, I would encourage you to talk to your leadership and whoever the designated leadership is, and let them know so that they can advocate for you all within the program to make those changes. But any access registered provider can provide services to our members, but depending on what your leadership with your tribal, sovereignty, your requirements for these providers, it's really up to them to make those decisions, because there has been abuse in the past. They're aware of it. They know more at a high level what has been going on in the tribal community that we're not privy to. We sometimes find out after the fact. So they know, they have reasons why, and I feel that I trust that they use their, professional judgment on making these changes and updates at the tribal level. And, because they are a sovereign nation, we're not going to come in and say, why are you doing this? You should do this. We don't have the right to do that. We have to be respectful.
Okay, and Annie did have a comment, which we answered in the chat, is that she was saying that some of the MCO, some of the transport providers were not willing to come on and transport because they're not willing to accept their insurance. And I did reply that if they're an access registered provider, then they do accept Tribal ALTCS program insurance because it's paid by Access. So I just asked her to let her coordinator know, and she said she would, those providers who are unwilling to transport our members.
I probably have a comment on your response, Sonny. They can transport, but it's really a case by case by each tribe. It really depends on the tribe. So it can't just, they are able to bill for those services, but really if it's something that the tribe says, no, we don't want you to do this, and we don't want you to come on tribal land, that's really up to them. But a lot of times it's because they don't know about the health plan. It Medicaid's the payer, Medicaid's the one who provides the PA, or sometimes at your level, but it goes through the Medicaid system. So sometimes we just need to educate them on that. So if you need access to support on that, we can do the outreach and provide that support.
Right. So I think, was there any other questions? Annie, did you raise another? Okay.
Yes, I did. So I don't have problems on the reservations, off the reservation. Like when they go to the hospital, and they're been discharged, and the nurses will call, and they'll say, we can't find anybody that will take your member because they don't take your insurance, because and I've heard it for years. And the MCOs have like a corporation. There's this group of transportation companies that belong to this, and only if your insurance is with that group, then they'll transport for you. So it's not always like a cookie cut or whatever, but it's just sometimes it is hard out there to find the transportation off the reservation. So I just want you to know that.
Yes, and those will be the case by case that would be sent over to your coordinators, and your coordinators will be able to assist whether to do the outreach to the provider and provide education, or to assist at another level where you need them to ensure the member receives the services that they need. So it's not an everyday thing, it's a case by case situation. So those should be reported to your coordinators.
Joni, did you have your hand up?
I did. I don't know if you can hear me.
Yes.
All of what everyone's saying is all familiar to us here. What I wanted to ask is, we had end of year taken on 6 NEMTs. During the interview process, they were all asked if they could provide X number of wheelchair transports and stretcher. They did all say they could. I don't think they were on a clear understanding of how many wheelchair transports they were really going to need. And when it came to stretcher, they all responded that they could. My question is, to this date, we can't get any stretcher transports out of any of them other than our own tribal transport, and that's limited because it's a 2-man transport and it's really limited due to dialysis. Is there some way aside from the contract to report this information to? I know you talk contract, I know you're talking, sovereignty and all that, but I guess it's because on our end, it hurts the member having to reschedule these critical appointments, having to be ready and then find out they don't have anybody there. I know for us, we have a wheelchair van. We have a van that we're going to convert to a wheelchair van, and we're going to utilize the driver and see if we can start taking some of our own wheelchair people that just have last minute cancellations on transports with some of these companies. We ran into 2 that we were told were not providing services. We looked up on the PR005, found out one of them was suspended. But is there anybody these types of incidents can be reported to through Access?
So you're talking about contracts. Are these contracts that were, or negotiations that were made by the tribal nation with these providers at the tribal level?
Yes.
Okay.
Yes.
So like I said, it's a case by case. I was going to just say Rydell can probably answer this, but let me just give my little input on this here. We at Access, like I said, again, we have registered providers. Any provider can provide any service to any of our enrolled members. Those services are available to our members. When it comes to tribal, if the tribal has, if they are saying any provider who conducts this kind of business has to go through their provider licensure at the tribal level, again, we at Access is not going to come in and contradict what their requirements are at the tribal level. That is something, if you are experiencing that, you need to go through your leadership. Your leadership needs to push it higher to the tribal level. And that's where the leadership should be advocating to say, this is causing access to care for our members. It is part of the benefit that the member receives. And if you feel like, hey, you know what, Access might need to be involved in part of this conversation, please let us know. We're able to be part of that discussion and try to figure something out. But if your health plan has already established a list, somebody should be maintaining that list. When it was provided to you, there should be either annual review or semi-annual review of those lists to ensure, are you still providing this type of services? Are you still doing this based on what you agreed to? Are you still doing this? If they are, then you keep them as a list. If you're seeing that they're starting to not provide that services, that should be reported back to your tribal leadership and say, hey, you brought these people on board and they said they were going to do this, but we're experiencing barriers now. And we're not in control of contracting with these providers. You, the tribe, are. So can you please revisit this? We really need you to, because there's abundance of providers out there, but because of this, legality reasons or whatever reasons why the business license reasoning, it really hinders our program from accessing these services that are available. So it's something that needs to go up. Again, we can be part of that discussion if you need us to be. But if the tribe has already established some sort of standard process internally when it relates to a certain kind of provider, that's when we have our hands tied. So we just need to make sure that they are providing it and you at the level are advocating for the member.
Okay, Rydell, go ahead.
Hello. Good morning again. I know this talk about NNT providers, I just kind of were like, I want to say something, I want to jump in because I know my end, what we do on our end with White Mountain. So where I sit in my position, I'm the director of Client Business Office. By resolution with the White Mountain Apache Tribe, we oversee the non-emergency medical transportation services, also the attended care services. So by resolution, my office oversees the services to ensure those services are provided to our community members of our tribe. If those providers are not providing those services, then it's up to our department to either eliminate those providers or bring in new providers. If they say they can provide stretcher and wheelchair services and they have not provided those services, then you go back to the person that, or even your leaders, and tell them, hey, they're not providing our services. We need to seek other providers and bring them in that are providing those type of services. And for the stretcher and wheelchair services, I think with Navajo Nation, I mean, we agreed to follow the standards of the IGA. If these providers or the tribe is not agreeing to continue services for our members with specific services, then we're kind of in violation of the IGA because we're not bringing the providers to bring in and provide those services. I'm sorry if I'm speaking too fast, but my heart's kind of pumping here. I was like, we have sovereignty. That's what protects us tribes. It's up to our leaders, however way your process is with your tribe. But for us with White Mountain, by resolution, my office oversees those services, and it's our responsibility to ensure that those providers provide those efficient services to our tribal members on our reservation. Bring in the right people, interview them, and if they are providing those services, let's get them a contract. So let's find out who's in charge of those NMT services and who's in charge of those intended care services, and you respond to them and tell them, hey, we need other providers that can provide other services, or bring in more providers. Understand or educate your leaders as well. So that's where I stand. That's where I sit. So I just hope that's helpful to you. So
Thank you, Rydell.
Thank you, Rydell. That was, like Cheryl mentioned, it's a very, you're very passionate within your community of advocating and being the advocate for your members. And it, we, like I said, we have our hands tied when the tribe says, we're going to limit this here to only this amount of providers. And we have met with some tribes where we say it's causing barriers. I say, I always have said, as a leader, you all are in the leadership role. We can't just sit here and complain. We have to do something about it. There was one point in time where our members, we can all speak to this, our members were being transported by transportation companies were not speaking the language. They didn't understand the language. They didn't understand the nature of the roads, the condition, the environment where they had to transport our members. They weren't being culturally sensitive. Every service that is provided in our tribal community, we, as in the leadership role, as a tribal long-term care program, you have to advocate for our tribal members to ensure that whoever provides services in our community, we are making sure that they are providing that service and being culturally sensitive. Do they understand the language? Are you ensuring that you're going to have a driver that understands the nature of our cultures and our language, so that they feel comfortable? Because they have to, any one of us is not just going to get into a car with anyone, right? We're going to make sure that they're safe. We're going to make sure that I'm safe. My life is in this person's hand that's transporting me to get my chemo, or dialysis. It's when the members tell you something, we act on it and we try to do something with it. If there's a barrier, that's where we speak up internally with our tribe. We have to respect the sovereignty. And being a tribal member myself, I do know that, I have rights. I want my tribal leadership to look out for me, and I respect that they do look out for me. And if there's any issues, I come at it as a way, there's these services available by access for these members. What can we do to ensure that that service is available at the time the service is needed? So that really brings us back to caseload ratio. I always say supervisors should have 0 to maybe less than at least 5 cases, because they have to be there to ensure these services are consistently available for the members and to ensure that when the need is there, you can easily coordinate services without any issues at all. So that way, you know what's going on internally with your tribal, decisions they're making, how is that going to impact the services that actually go to the members. So thank you for the input. I really appreciate it. I think we're kind of running behind on time now.
Yeah, a very good conversation though, and thank you everyone for your input. So go ahead and go next. Okay, so we're going to take a quick 10-minute break. So go ahead and get up and stretch and come back, and we'll try to get through the rest of this as quickly as possible. So come back at 11:13. Thank you.
Let's go ahead and get started again because we're bumping up against time. So is everyone of my team members back?
Yes, I'm back.
I'm back.
I'm back.
Okay, let's go ahead and continue.
Charlie?
Good morning, everybody. I will be presenting today on the ALF calculation tool. Next slide. So this is just a reminder. We're going to have just an update on this tool that was sent out around the end of December, and then it was revised because there were some issues with it about not calculating. So it was resent out on January 4th by Sani. So, excuse me. So this is our ALF calculation sheet. It is to be used for only ALF residency, room and board calculations. As you all know, the AHCCCS does not pay room and board for members' residency in an ALF. This is a really nifty tool that Rachel created a few years ago, where in all the highlighted yellow areas, you will just be able to put in the information on the member. Next slide, and it will calculate for you. ALF placement for ALTCS members. Again, AHCCCS does not pay room and board. It is a person-centered service planning goal for the member to be in the least restrictive environment, and income confirmation must be understood. You're going to ensure education regarding room and board is understood by the member and their family representative, and you're going to ensure an accurate ALF calculation sheet is completed prior to the member going into the ALF. Next slide. Here's an example for Minnie Mouse. She and her family have decided that she wants to go live in an ALF. Even if it's just temporarily during the winter season when nobody can get to her home. So we are going to first of all go to the PMMIS CA 168, the member income screen. And here's an example. Minnie Mouse, as of December 2022, gets SS disability income in the amount of $777. That is the income that she gets monthly. This is the income you're going to use to enter on to the calculation sheet where it says member income. Next slide. And we don't want to mix it up with the share of costs, because share of costs is only for skilled nursing residents. The share of cost is a monthly amount a customer must pay towards the cost of long-term care services. The share of cost is only used for skilled nursing facilities. The share of cost is recalculated each time there is a change in a member's income or amount of the share of cost deductions. The share of cost amount is based on the customer's counted income, living arrangement, and allowed share of cost deductions. It is formulated by Access Eligibility financial staff, not the case manager. Ensure member rep understands share of cost. Next slide. Any questions? Ernestine?
Sure. They asked if eligibility updates the CA 165 screen.
No. Or I'm sorry. Yes, they do. Yes. They are the only ones that can update those screens, is Access Eligibility, the financial.
Right. Okay. Any other questions? Thank you, Cheryl.
You're welcome.
Go next. Bandana.
Hello, everyone. Today I'll be going over project overview and service line reports. Next slide, please. I know we have already covered a lot of this today. Please, can you go to the next slide, Charlotte? Here is an example of each. I think you missed one slide, Charlotte. Okay. Here is an example of each with no response received from tribal programs for no service line and projected overdue report. Next slide, please. Here's an example for each with response received from tribal programs for no service line and projected overdue reports. Next slide, please. If you are one of the tribal programs that have been returning the report to us by the date reflected on the report, we thank you for your cooperation. If you have not been sending the report back by the deadline with comments, please begin doing as soon as possible. Next slide, please. Thank you. Any questions?
Thank you, Bandana. Okay, and we're going to turn it over to, oh, I'm sorry.
You raised your
Nana, go ahead.
Yeah, Bandana, if one office doesn't have a anything on there, like say like it's reflected on there, but they don't have any reports to report. Do we just leave them off and we just don't bother with it? I think I'm kind of mixed up. Anyway, so we get these reports. Sometimes you say that you don't have to respond, but then on the service line report, there's no offices that are indicated. There's some offices that are indicated that have no service line reported on their offices. We don't have to report anything, only those that are on there, right?
Only those that are reflected as requiring a response. If it says a response is required, then you would need a response. But if it's not like overdue, that doesn't require a response. Or if it's missing service lines, we need some sort of response.
Okay, the other thing is that we have one member that's in acute care only, and it's been like that for a couple of years. And
So just put
we
D
keep-
placement on there.
we keep having to do a response because of that. And it's like, this person, we did the EMCR, we did all of these things that you asked us to do, but we're still being asked to do a response in that area.
Well, if we're seeing it as a D placement and we understand that it's why it's showing up there, that should come back, and that's something maybe we can go over on our side, is if it's coming up and it is D placement and we see that's really not a response that is required, we can train on that on our side. Okay. So.
Okay. Thank you.
Sure. And
Just a quick
before
question.
Maria, I think Vanessa's going to present just for a moment.
I believe there's a question that was coming from someone.
I had a question. This is Ernestine with ALTCS. When you say response, you're referring to CA 165 comments, correct, on both reports?
We're talking about, well, it would be a response on there, but also on the report. If it shows on the report, then yes, we do need a response on the report as well as on CA 165. If you have comments out there, we're going to see that you've already made comments, you've already made attempts and everything. That would be, we were able to see that, and we can say on there, we see that the member provider has made, not provider, the case manager has made multiple attempts. In that case, we can see that those comments out there on CA 165. We may ask for an update as to what is going on if you're able to outreach or find out what is, what else is going on. But does that answer your question?
I want to be the devil's advocate in this, Sonny. So if I had an update back in November that was commented in the CA 165 for the member being overdue, okay, it shouldn't be that long, but well, in Diana's case, maybe there was some sort of disenrollment that was supposed to happen, but it's still out there. They're still showing overdue, right? And I've already addressed it. It's in my comment screens. And so when we're sending out the report, are the coordinators saying no response required? Or are they wanting response, even though we know that the member, say, take hypothetically, members incarcerated. They already told us they're going to be in the, remain in custody by whatever, judicial system. Then we know, and are we still asking? Because during the public health emergency, some members are still on, right? Where they're not doing the disenrollment. So in that instance, even though our team already is aware of the situation, do we consistently ask for that information?
No, if we see that there is comments in CA 165 that says that the member is incarcerated, we would put that on our report. Member is incarcerated, no response required, but well, they may require an EMCR to move the member out if the member is incarcerated. That may be the comment is, please submit an EMCR to indicate that the member is incarcerated, or whatever the case may be. But if we see a comment that is repeatedly over and over again, the member is in acute care and it's showing up, we should be able to say on our side, the member is in acute care, no response required on this report, because we already see their comments on CA 165, but it's a case-by-case basis depending on what is going on with that specific member.
So if the comments are updated by the CMs in the CA 165, and if they're current, then the attempts were being made, dates were put in the CA 165. If those comments are current, we don't keep asking for the same information over and over again.
Correct. If we're not correct, if it's in there and we can see it's real recent and they're repeatedly going out, we can see that, They're trying everything they can. There may be something that they outreach to us to see what else we can help them with. But correct, that shouldn't be on there repeatedly time after time. And if it is, that's something that we can train on our end.
Okay, thank you.
Okay, thank
I
you.
think Cheryl had her hands raised too, so I don't want to
Go ahead, Cheryl.
bypass that.
Yes, I was just gonna answer the question quick and easy. Is that when the reports go out, we as coordinators are responsible for knowing what the case managers and where these members are at. I have 2 tribes that have one each has a member that is in D placement contract type T, so is only receiving acute care only services, and that's the member's choice. So on the report, I put the member is in contract type T, ACO, D placement. I know that. So I go ahead and just gray out the area under the tribal response. I don't need a response back. The same with the 029108 report is the same way. If there's no response needed and there's comments in the CA 165 comments that also tells me that the case manager knows the status of their member, then I grade that area out where the tribal response is, because it is very time consuming to go back and forth and back and forth. As long as I know that the assigned case manager is following case manager standards by planning and monitoring, then I'm good. We're good. We're on the same the same path of understanding where the member placement is, because it is very important that we all know where the members are, mainly tribal assigned case managers. So that's what I wanted to add. Thank you.
Okay, and Casey did report that he has a loss of contact, and they processed an EMCR for closure. Eligibility will not close, which is true due to the PHE. We can see those comments, and I understand you're saying it keeps coming up showing for comments. We can train on that end and discuss that and find out if there's some issues. But Casey, we'll look at that. Okay. Thank you. All right, Vanessa.
Hi, everybody. So I think this slide, Sonny's for our presentation, and then the next slide after ours will be introducing Maria.
Oh, okay. Okay. I thought you said it was before her. So, this is yours. Oh, this is ours. I'm sorry.
This is ours. So
yeah, you're right. So this is our chain of command. We're just going to go over this. This was brought up, is that could we have a list of how the chain of command works? So go ahead and go next. Okay, and this is on the case management side. The case management coordinators are Cheryl Begay, and she oversees the Native Health, White Mountain, Gila River, Tohono O'odham, San Carlos, and Hopi. And Bandana Chetty oversees the Navajo Nation and PY, Pasquayaki. And I am the Tribal ALTCS program manager, and both of the coordinators report through to me. So that's our chain of command. Is first of all, you would start with your coordinator. They will do their attempts. And go ahead and go next. And so first of all, our first option, as we try to always train on, is that the case manager should first case manage the member issue with their supervisor to attempt to resolve it at the tribal program level. If they are unable to do that and unable to resolve it, then they would escalate that to their assigned coordinator in an email and provide the coordinator with a list of the attempts made along with all the pertinent details. The assigned coordinator will make every attempt to try to resolve it at their level. If they've exhausted every effort that they can make on their at their level, then they will escalate it to myself by emailing a list of the attempts made by both the coordinator and the case management supervisor and all the pertinent details. At that point, I will attempt to resolve at my level. And if I'm unable to resolve at my level, then I will escalate it to the Tribal ALTCS administrator, who is Rachel Conley. And then it will, with all the details, I will, let her know all the details that I have, attempts I've made, the coordinators made, the case manager, supervisor have made, and to resolve it at that level. Next.
For the Tribal ALTCS clinical team, with our process, it would first go to Charlotte Little, who we call Charlie, as the Tribal ALTCS specialist. Then it could escalate to Maria Dorado, our new Tribal ALTCS nurse. At that point, it would then be escalated to myself, the Tribal Clinical Program Manager, and we do list all of our emails above. Next slide. Following a similar process as the case management coordinator team, the case manager should first case manage at the member PA issue with their supervisor to attempt to resolve the issue at the tribal program level. If the CM and the supervisor are unable to resolve the member issue at that level, then it could be escalated to the Tribal ALTCS specialist, Charlie, in an email. And the specialist can provide any services as far as what she would be able to resolve at her level. She could then escalate it to Maria. If Maria is unable to resolve the issue regarding PA at her level, she would escalate it to me, and then I would take it to Rachel Connolly. Next slide. Does anybody have any questions?
Are you able to provide an organizational chart?
We don't really have an organizational chart per se, but we can provide one. Yes.
We have one, Sonny. We have one that we.
Oh, we do?
Yeah, we
okay.
do have one. We can provide that.
Okay, I haven't. Yeah. Okay. Next.
Okay, so before Maria does her presentation, I did just want to do a short introduction to her. Maria Dorado has been processing all the Tribal ALTCS PA requests. She's picked up everything very well, and she's been a great addition to our team. Maria?
Good morning. It's Maria Dorado. I'm going to be presenting on SNP and ALF prior authorization requests. Next slide, please. SNP and ALF prior authorization process. I received the packet. The PA nurse will review dates of service, supporting documentation, letter of approval, or additional information request is sent to the case manager in the event there's missing information. Next slide, please. For our overview for SNP for 2022, we had 857 packets, 268 were duplicates, 69 had missing information, 34 no PA required, 4 were pended PA, and the total of approved 482. Next slide. For ALF 2022 overview, we had 433 packets. Of those, duplicate were 123, missing information 89, no PA required were 5, no pended, multiple members within a packet were 2, PA under review 3, and approved was 211. Next slide, please. So the most pertinent noted missing information was the supporting documentation, wrong provider ID or no provider ID, member ID, and or it was illegible. Next slide, please. What is supporting documentation? Supporting documentation refers to written information for services rendered to the member by the staff. And this would be a nurse, an aide, a CNA, a caregiver, respiratory therapist, physician, or nurse practitioner. Examples: if we have received a packet on behavior for a service rate for a member, then we're looking for CNA documentation, nurse documentation of the member's aggressive behaviors. There could also be doctor documentation as well. For dialysis, we were requesting dialysis sheets. For tracheostomy or ventilator, respiratory notes, please. TBI rate, a physician note indicating TBI diagnosis. Next slide, please. Fee-for-service form, complete thoroughly. Please write the type of specialty request in black, right under where you're asking for the specialty rate. Provider name, which is in green. Provider ID, which is in pink. This is because we have many facilities that have similar names or fall under the same facility but different locations, and they have different provider IDs. So it is important that you do provide a provider ID, please. And then, of course, the dates of service, which is highlighted in yellow. Next slide, please. Other tidbits. Supported documentation within 1 month of requested dates of service. So, for example, if you're requesting from January to March, I do request that you do provide supporting documentation from December. Documentation should show multiple occurrence issues for services rendered. Remember that we're working together as a team, and reach out to Charlotte Little if needed. And I provided her email address. Next slide, please. My contact information, email, plus the PA office and fax and direct line. Next slide, please. Any questions? Thank you. That's it.
Possible for San Carlos to get our quarterly report for our PA submissions?
Vanessa, can you help me with that one?
You're asking for the quarterly report?
Yeah, for San Carlos.
Okay. Rachel, is the coordinator team providing the reports? You're talking about for the pendant PAs or the PAs in general?
I think she's talking. Go ahead. I'm sorry.
Yeah, for the prior authorization.
Yes, we can, Ernestine, we can provide that to you. I know we've talked about it last time, and I know Navajo Nation really wanted a copy of that. We just haven't, we've been all so busy with EV and everything, but we can, it's an internal report that we use for ourselves, but it is broken down by tribes. So we can send you a summary report if you need it. And this will probably come from Sonny or myself. It won't come from the coordinator level, because we do look at those reports at a high level. It is more of a leadership level that we review it to ensure that everyone is doing what they need to do. But we can do, it's not that hard. We can just do a sort by health plan, date span, and then get it over to you.
Annie, a question?
I do. Do we have a new fax for DSM? That the fax that Marie just showed us is not in my session that I use to send rates.
Maria, can you, or Charlie, can you go back one slide just to look at the facts?
What you displayed was the provider PA they use.
Yeah.
This is the longer care fact.
The one displayed is not on the format that he's
Yeah, because I don't use that one. Okay. Thank you.
Yeah, I wouldn't use too myself.
Does that need to be updated before we send this PowerPoint out or post this online?
Yes, I'll.
No,
Go ahead, Vanessa.
Oh, the fax number is the long-term care fax number.
It should be listed on the actual fax cover sheets that are out on the
She's talking about,
Access website.
she's referring to the fax form
The fax.
document that you
Yeah.
displayed earlier.
Oh,
That's not the one.
Charlie, could you go back one slide? I think it's,
Is it another one back?
I think it's maybe
One more. There it is.
this one.
That
There you go.
That's
Wrong
for
one.
providers.
That's
Not
the
our-
provider fact sheet.
Yeah, so we do accept the fee-for-service authorization request form. There's also the case manager form that has a different form on the Access website. I can put both of them in the slide so that you have both.
I think we need to be consistent. If I know that this is a form, this form right here that we're showing, that's used for both AIHP and Tribal ALTCS. So I think we need to be very clear on what fax. If this is maybe just black out the fax number on this one, and just as long as the next presentation following shows that that's the fax number they need to be faxing it to in the presentation, I think it'll just make it clear.
Yeah, the other form is a medical documentation form that can also be used.
But we just want to, I think the question is, they want to make sure whatever fax number that is showing, there may be other fax numbers showing on these forms, but we need to ensure that the correct fax number for the tribal long-term care needs to be on here. So at the bottom of this form, does it have a different number?
No, the bottom on the form, they should be faxing to the LTC fax number, which is the long-term care fax number. That's the 602-254-2426. If they're sending it directly to the prior authorization form, Leonore's team will have to filter it over to the long-term
reroute it.
fax. Yeah, they will reroute it as long as it's correctly filled out, because sometimes the providers will send it to prior authorization, but they don't fill out the form correctly, which results it going to another team, and then it gets closed where they just get the response to fax it to the case manager.
Okay. So we can go back, and as long as this presentation shows that we have the right fax number of where they need to send the request, then that's good. We can go back and look at this form and update, just to avoid any type of confusion.
Okay.
So,
And I point out the
you're correct.
presentation is
It does.
Go ahead,
Go ahead,
Ernestine.
Ernest.
I just want to make a clarification that the presentation is for level of care above level 3 care and behavioral health ALFs, right?
Yes.
Thank you.
And Casey, you're correct. The forms, the ones that are out, the actual forms out on the Access website, I believe if you're talking about the fax cover sheet, that is being updated to reflect the current governor. But as far as some of the other forms, we are updating them as well, and we'll get them out on the digital toolbox as soon as possible.
That's probably a priority because we did get notification on that internally. We got to do that ASAP.
We're working
Yeah,
on
right.
it. Correct. Yeah.
Right now, the website still shows all of them with the old governor's name listed.
Right. Yeah, that is something we are working on, and it is a priority. We had, unfortunately, a couple other things that we were working on, but that is not, it is not put on the back burner. It's a urgent thing that we're working on. So it should be done. I would think it should be done by this Friday or by Monday at the latest.
Yeah, I know that our AD has made it a priority to ensure that all those forms are updated. So we're working on it internally. I think
Okay.
Casey has his Is it Casey that has his hands raised?
Yes, I have a question. I posted it in the chat box, but the behavioral health notes, that information when I request it from a SNF or a facility, they usually send a large amount of paperwork, and a lot of it is not really referencing any behaviors. It's just like all the different medical stuff and notes, different type of notes and medication, not necessarily relating to the behaviors. And when you look through it, you kind of look for the, I guess, notes or like nurses' notes and stuff. But my question was, sometimes they're like 50, 80 pages of information. And my question is, would something like a summary from a social worker or a nurse, kind of like a one-page summary, be sufficient or not?
We want to show multiple, like for instance, if it was behaviors, multiple instances of those behaviors. So, like the temperature, I don't need. I do like to look at what type of medication they're getting. Sometimes I get temperature, their weight. Those I don't need. Social services notes does help because sometimes they do document behaviors as well. I hope that answers, but I don't need the like 80 pages. Just maybe a couple of weeks worth of notes from the previous month. But social services, like I said, is helpful. CNAs or aides, nurses' notes. If there's a psychologist that sees it or a psychiatrist that sees the member, that would be helpful as well. I hope that answers your question.
I do want to caution though that just be very careful with that, because we have nurses here in at AHCCCS who specialize in reviewing those cases. So if you're kind of weeding through things that is being submitted to you and you're making that determination of what needs to be sent to AHCCCS, and maybe maybe you pulled out something that could be a really big piece of making that decision to continue the approval or for the admission, then just be careful, because I really don't want to advise and say, no, you don't need to send in this or you don't need to send in that. The more information you have, it's really good to assist our clinical nurse to make that appropriate decision, because we do want to look at the member holistically. There could be, I know, San Carlos, Yvonne has made some observations, relating to UTI, and then, adding that to the type of services the member was receiving. So more information we have really does help our nurse, who's actually, has the credentials to make those medical decisions, to say, if she has to work with our medical director, we can pull them in to kind of help along the way to say, yes, this is an appropriate type of service for this member due to all the documentation that we have. The more information we have, I know it's a lot, but it's not every day you're sending in these notes. Yes, it is a lot because we only have one nurse who actually processes all these requests. So you may be looking at it at your level, for a certain amount of members, but she looks at every single one of them, every single page. And the more information she has, it gives her that justification to make those approval. So it's a lot, yes, but we're not doing the face-to-face. We don't know the ins and out of what is actually really going on. Maybe something happened within this past 90 days that's not on the previous notes. Any changes that has happened, that's where it's their specialty to make those decisions based on those clinical notes. I'm sorry, it's a lot, but it really does help to justify the cause, especially when we get audited by CMS.
Okay, thank you. Yeah, I usually send all of it, so I was just kind of posing that question. Thank you.
Okay, and I would agree with Rachel. I mean, a member could have multiple reasons to be able to probably justify a specialty rate, but the more information you have, it's not like a consistent 30-day note that we're looking for, we're looking for like a 30-day date span as far as like how many behaviors are they having? Is it something that is a chronic issue? Because a lot of the reports that we do get, they do have the diagnosis summaries, what kind of meds they've been on, how long have they been on those meds. A lot of our members have been with the program for a really long time, and they have been on those specialty rates for a really long time, as far as, you know, some of them have been placed in their placements for years, but we just need to make sure that we can still justify that they're still at that level of care and that those providers are still providing that specialty service that they say they're providing to them. So the more documentation, the better. But thanks.
Yvonne, you had a question?
No, it's not a question, it's a comment that you all know I'm a nurse and I worked in many different areas. I had specialized in physical assessment. In different states, he had different credentials and stuff like that. I think you all know that since I was in ALTCS in 2016, I advocate for nurse for practically every place because, like you all brought up, it's true. And it's easy to catch for a nurse to see, but for other people, no. And as I go through the chart, I review the chart. I see everything. If I see something different that person didn't see previously, especially if I had that patient myself in 2017-18, there's some changes. If there are changes in their physical being, their connectivity, or diet, and etc., that's all cause and effect of the body system. If you see medication, but what I noted too, that some medication does not work well with the other medication that was put up. You have certain side effects according to the condition. And that's when I go see the doctor personally. I call them and I ask them questions. And that's where the nurse is good to have a nurse. If you can get a nurse, you can take the time. I spend 1 day a week going through every chart and reading notes from the hospitals. That helps, in clinics and specialty. I read everything. I look at the blood pressure. I look at their age. I look at their education background, because that does make a difference in your well-being aspect. So that's what I'm saying. Nurse is, if you can get a nurse, get a nurse. Thank you.
Yeah, and if you don't have a nurse, that's where our nurses are here to provide that support. You know, we not only have Maria, but we have Vanessa, who's they've actually worked in these types of settings before, you know, and they even have as many nurses, they have their own personal life where they deal with having to use that nursing skill. So we have, good team members on the access side, and not just Vanessa and Maria, but we have other nurses, that have the credentials to make those decisions, that we can trust they're making these decisions. So that's where we can kind of brainstorm on our end, especially when it comes to transplants. When they're looking at transplant, a group of nurses actually get on together to discuss these things. So if you don't have a nurse at your level, I would not recommend you piece some of these submissions up and submit them, because we really do need to see the person as a whole, and that's really the main focus of it, is seeing the person as a whole and making sure that, our professional, I can't speak on what nurses need to do. And I can't say, you can go ahead and submit this, or you can go ahead and submit that, because that could be an important tool that they need to make a determination on the continuation of stay, or either to admit a member into a specialized unit with those services. So the more the better. It's a lot to submit, but at the end, we know that the appropriate care is being provided to our members and people who are specialized in those coordinating, helping to assist in coordinating the services. If it's not at your level, at least at the state level, we're working as partners. And that's what we agreed to on the IGA. We're working as partners to make sure that we are doing the best that we can for the best interest of the member, We're not just pushing all of this on you all and saying, you make the decision, it's up to you. Because really, I was listening to a podcast early this week, and it's like, we leadership have to take responsibility for what goes on and helping and being there to support our case managers, these case managers who report to us. They look to us to seek help for assistance and barriers. As leaders, we should know policy. We should know what is required of us by the state, because the state does fund these services, and long-term care services, and case management is a big piece of that. That they're at the ground level. They're the ones who actually is driving through the mud. They're the one driving through the snow. They're the ones who's driving through the monsoon season. They're the one who actually does the face-to-face. The advocacy has to happen at the leadership level in the tribe, and making sure that we are looking out for the best interests of our case managers, making sure we're reviewing the caseload ratio, making sure that we're not overwhelming our case managers, and making sure also at the higher level that our leadership, our supervisors within those programs know they can go to their leadership and advocate and say, hey, look, this is what we're seeing. We're seeing issues. And like Rydell said, if it's part of your responsibility to know what is in the IGA. You are accountable to those things. This is something your leadership agreed to, is something that cannot be done at the time or even during the time that the IGA is active. You can always speak up. And at my level, at the state level, I always say, no one's perfect. We're not perfect. My team is not perfect. They make mistakes, and many times they will tell me, hey, I did a boo-boo, or I made a mistake and this happened. And we're able to walk through. We don't come in with a stick and, chastise everyone. We try to get everybody back on board. Let's get back. Let's get central again. And because any decision we make, it really does impact our members. And as I always say to everyone, within the programs, you all out there in the tribal community, you are a sovereign nation. Practice your sovereignty. You know what is needed. You can advocate for your long-term care programs. There's an appropriate way to do it. When you are in leadership and we're playing the blame game and we're passing the buck, it really does. We're impacting a service that is available to our members. We're tying those things down. So no one is perfect. There are issues even within our leadership. We just can't blame our leadership for everything. Come with a plan. What is the plan? And that's what we're really trying to do within Access is each of our employees, we do through our coaching. As leaders, we have to coach. What ideas do you have? Let me challenge you on this. Can you do this? Can this be done? Instead of saying it can't be done or we're not going to do it and you're forcing me to do it. We're trying to improve processes, because if you see a barrier, how can we improve it? How can the state be part of that improvement? How can we support you in whatever way we can to make sure that you are getting these services coordinated for our members? And I always go back to, I'll probably end it with this. For me, I'm very passionate about what I do, because I had a father who I knew he couldn't do many things towards the end of his life, that he couldn't do many things on his own, but he was very stubborn. He did not want to come live in with me in Phoenix. He wanted to just live on his own. I want to do this on my own. Very resistant. I put up cameras, I put up security system. I bought him a security alert myself, just so that I could make sure that he was okay. But he would take off his medical alert, put it in a drawer far away. And luckily for those cameras, I said, my dad's not moving. The door is open. Why is he not moving? And by midday, they found him. You know, he had passed away in his own bed, and we live in an area where the police, you know, the fire department is only like 20 minutes, not even 20 minutes away, you know. And I go back to think about that, and I said, what is our purpose? This is our loved ones. This is somebody's loved one. This is somebody that relies on the program to make sure if it's a benefit and there is a barrier to that long-term care benefit to be provided in the tribal community, please speak up. Please tell your leadership. If your case managers are reporting it to you, have them escalate it. Give them a voice to escalate that. Give them a voice to where, you know, if they need help, give them a voice so that you can take it up to your leadership and express that. I know there are some tribes who really do a lot of advocacy. They provide that in-house training, in-house support, in-house clinical service, medical services, behavioral health services, all in one shop. I know Pasquiyaki is really, really involved at that level, where it's like a community place where they go to get all their service needs taken care of. You know, network with each other, talk to each other. How does this happen? Why are you successful in that area? That's why we bring everybody here to network, because our program is very, very unique. But I would say, you know, it's not a, you know, we don't crack the whip. I don't want it to ever come out that way. You guys are free to tell me. I mean, I have supervisors who come to me and tell me things, and we brainstorm and we walk through and talk to things. That's what we have. We're an open door policy for the state to make sure that we are helping you all to be successful. You know, we were successful in the EVV. I mean, that was kudos to all of you guys and your case managers who were actually communicating that ahead of time. You know, we have so many success, and it takes the team here and the previous team who kind of built that foundation for us. You know, we didn't just come in and change and create all this. It took a history of previous leaders internally here at Access to make sure that we carry on their legacy. We carry on some of the things that they've implemented. We can never just push that aside and never give them credit for what they are owed, you know. So, and the same way with you all. You guys have been, most of the leaders here have been in those positions for a very long time, and you have a legacy. You have made changes, and you have voiced out, even though you got in trouble, some of you have voiced the concerns for your members. And so with that, I do want to appreciate it. We all feel that way. There is no personal gain for any of us. We could get a job somewhere else with getting paid more money than what we do here, but we do it because we're passionate about what we do. And we do it because we want to work with you all. And we do it because we know and understand those barriers. So again, thank you so much for attending. Please take these trainings back to your programs. Please let case managers, even if they're on the web, maybe have them review it. Please do that, because the more they know, they can really support you. My team, I have an excellent team. When I need them, they're on it. When I need them to do something, they get it done for me, you know, and they really do. And I don't just pass the buck to them, you know. When they need me, I'm there. If they need help, I'm there. And please make sure that that continues on your end, because we need them. We can't lose those case managers. They're a vital asset to this program. And they know and they speak the language, majority of them. They know the culture. They're connected with the community. We need them. So whatever you can do to support your case managers, and whatever changes that we can make without having to overstep or the tribal sovereignty, you know, please keep that in mind. You know, we really need, from a state level, we have to respect you all, and you have so much power. The tribe has so much power in their hands that they can make these changes. So thank you again. Were there any other questions? If not, we can go ahead and close. We just went 5 minutes over. Thank you, Maria, for Maria and Vanessa getting us back on track. And Bandana, it looks like you rushed through yours. And Cheryl, thank you so much My team is excellent. They do their best to do the best they can to provide that assistance to you all. And so please don't ever be afraid to reach out. You know, for me, I don't like to hear complaints. I don't like to hear, you know, people bashing their bosses. You know, there's that, we really have to be positive. We really have to work together as a team and have facts. Factual basis does make changes. So please make sure, keep that in mind and re-educate or redirect or provide these resources to your case manager. Whatever the need is within your program, you have that in your hands. So hopefully you use these tools to continue to improve and shine for your tribal program. If there are any things that you guys have accomplished, some things that you want us to highlight at the state level, please send those over. Anything that you have done at the tribal level regarding healthcare, long-term care, or even just wood hauling, you know, that's something that helps the member. Highlight those things, get it over to us so we can say our tribal community is doing this. You know, we always do that. So thank you so much for attending. I really appreciate all of you for all the hard work that you do. And please let your team members know that we are very, very thankful for all the work that they do and continue on. Hopefully we see more improvement as time goes by. Thank you so much.
Thank you, everyone.
Have a great day.
Thank you.
Thank
Thank
you.
you.
Bye.